All right, this will be a relatively quick one, just on some more USMLE cardio style questions. The vignettes are going to be short, but we're going to really do this to kind of trigger your kind of gut instincts on a lot of these concepts. There'll all be multiple style choice questions. We'll try to get it done in less than 30 minutes. So I'll just ask, like when I present a question, pause your screen, consider it, really think about the physiology and the pathophysiology of the question, and then I'll give a brief review, and then we'll move on. All right. Um, so first question. We have a 68-year-old man with long-standing hypertension who has an acute hypertensive emergency. I want you to think about which PV loop change is most likely immediately after a sharp rise in afterload. Okay, so consider A through E, pause your screen, and then I'll discuss. All right, so the answer is going to be B, and let's take a quick step back, right? When we think about hypertensive emergency, classically in the literature, it's a systolic over 180 and or a diastolic over 110 to 120. The blood pressure itself isn't super important. Obviously, the blood pressure is going to be elevated. What's important is the patient has signs of end organ damage. So kind of going head to toe, could be headache, could be TIA, loss of consciousness, stroke, could be visual changes, or you see retinal hemorrhages. Or sometimes we call them like arterial nicking, or cotton wool spots. You might also see kind of moving down, chest pain, shortness of breath from pulmonary edema, abdominal pain from mesenteric ischemia, flank pain and or hematuria, and then, numbness, tingling in the fingers. Those could all be signs of end organ damage to kind of classify as hypertensive emergency. Hypertensive emergency can lead to fibrinoid necrosis secondary to malignant hypertension. So we get underlying damage to the vessel that can stimulate a whole lot of things. Yesterday in my review lecture, we talked about how malignant hypertension can lead to a thrombotic microangiopathy type section. So if you want more on that, go look at it's one of the first cases in my PowerPoint. So when we think about our PV loop, right, my gray here is normal. And so at this point that I'm kind of circling with my cursor here, that's my end diastolic volume or my preload. We have to get up to a certain level of pressure, right? So the x-axis is volume, the y-axis is pressure. We have to get up to a certain level of pressure in order to outweigh the afterload so we can push open the aortic valve and then kick out my blood to the system. When the afterload, when the systemic vascular resistance, the systemic pressure is elevated, we've got to build up the pressure a lot higher in the left ventricle in order to kick out. And so because the pressure in the system is a lot higher, well, the left ventricle can only increase its pressure higher than the afterload pressure for a limited period of time. So that valve pops open when we finally beat the afterload, but the valve is only able to stay open for a short period of time. So my stroke volume ends up being limited, okay? So here in B, the stroke volume is low, right? Stroke volume would be from this point to this point, okay? So it's much lower than my control. You also see the end diastolic volume is the same, but we'll talk about how on the next beat, it's going to be different, right? And so then you can see here the end systolic volume is actually going to be higher, right? Because if I'm kicking out less blood on the contraction, well, there's more blood in the left ventricle, right? After the end of systole, right? End systolic volume. And then if you think about it, right? If the left ventricle is now holding just a little bit more blood, right? So let's say in a perfect world, when the afterload is totally normal, your left ventricle gets rid of all 100% of blood, right? That never really happens, but just for the sake of example, kicks out all 100% of the blood. So the end systolic volume is really low, right? On the next beat, right, the next diastole, the left atrium will dump all of its blood into the left ventricle and we'll start again. Well, in this case, because the left ventricle hasn't fully evacuated all of its blood, right? When the afterload's super high. Well, it's already starting with a little bit of blood in its chamber. And the left atrium's still going to dump the exact same amount of blood into the left ventricle, right? On the next beat, on the next diastole. So now the left ventricle has whatever the left atrium has given it, usually the same amount of blood, right? Plus the little bit of extra blood that it wasn't able to release because of such high afterload. So the end diastolic volume, the preload, ends up being a little bit higher on the next beat. My end systolic volume is going to be elevated, right? Because we're not getting rid of everything. And then the stroke volume is low because, again, we're not getting rid of everything because of such high afterload. All right, there it is written for you here, and then we'll move on. All right, a patient received an IV medication that increases inotropy. Which change is expected? So look through A through E, pause your screen and consider. So here again, it's going to be B. The end systolic volume should be low, right? And the ejection fraction should go up. So if you think about it, right, the inotropy is kind of the slope of this curve. So this gray box is my control. The low inotropy, so something like a beta blocker or heart failure, right, would be a very low slope, this green box, and then a higher inotropy, such as giving a drug like dobutamine or milrinone, can increase your inotropy. It increases your slope, right? Remember, dobutamine is a beta 1 agonist. Okay, really helps the heart contract. Milrinone is a PDE antagonist. So it increases some of my vasodilatory molecules out there, but it also increases CAMP production, which downstream activates PKA, which increases calcium influx and helps my smooth muscles in my heart contract. Okay. So the inotropy goes up. When the inotropy goes up, if you see, right, the heart's able to contract harder. So the end systolic volume ends up being lower because we're able to like fully get rid of all that blood in the left ventricle. So there's less blood at the end of systole left in the left ventricle. And the ejection fraction goes up, right? We're able to get out more blood at the end of the day, right? That would be your example of increased inotropy. All right. Let's keep it moving. All right. We have a 55-year-old with metastatic lung cancer presents with hypotension, JVD, muffled heart sounds. An EKG is obtained and shown. Which other physical exam finding is likely to be seen? So consider A through E, take a look at your EKG, and then make your best guess. All right, in this one, it is going to be your B. Okay, so B is describing pulsus paradoxus, and I want to kind of go back to the EKG because I'll use this in my explanation. So this patient, right, there's a lot of things going on in this vignette, even in such a small vignette, that you kind of got to pick up in order to answer correctly. So first things first, who is my patient, right? A little bit like middle age, older side, history of metastatic lung cancer, that's going to come into play here. And then they have the classic Beck's triad, right? Hypotension, JVD, muffled heart sounds. In real life, you're probably not going to see the full triad. On MBME exams, they might like give you a handout and kind of lay it out all out there, or they might kind of spread it out throughout the vignette, and you have to kind of be looking for things. I'm giving it to you, I'm literally spoon feeding you, right? Just to make sure we understand this concept, but understand in real life and on board exams, it might not be this easy to recognize. So what the Beck's triad kind of keys me in on cardiac tamponade, or at least impending tamponade. We also look at this EKG, right, and take a look at my QRSs, right? Look at how small they are, right? We consider low voltage QRSs to be less than one box, right? One bigger box. And you can see they're all just about like one box or a little bit less, right? These are low voltage, okay? So like less than 5 millimeters. You can also see if you look really close, right? If you're astutely looking, this one looks a little bit bigger than this one. And then this one's about the same as the first one, and then it's smaller, and then bigger, and then smaller. So we call that electrical alternans, where the QRSs kind of get a little bit bigger, then smaller, then bigger, then smaller, then bigger, then smaller. So when I see electrical alternans with low voltage, now I'm really keying on cardiac tamponade. So if you think about tamponade physiology, we start with some sort of pericardial effusion, right? So in my pericardium, I have the visceral pericardium surrounding the heart directly. Then I have a small little gap, and I have the parietal pericardium surrounding that. And in that gap, there's a little bit of fluid, right? When you have inflammation to the pericardium, you can get pericarditis, right? It increases permeability, and we get some extra fluid kind of in that pericardial sac. Now, eventually, that fluid can build to a point where we have a huge pericardial effusion. And when that effusion equalizes pressure on all 4 of my heart chambers, and it equalizes the diastolic chamber or the diastolic pressures of all 4 chambers, that's when we get into tamponade physiology. So if you think about it, in my cardiac cycle, 2/3 of my cycle is diastole, 1/3 is systole. Diastole is how is perfusion happening in between contractions, right? So diastole is super important to get blood from chamber A to chamber B, from chamber B to chamber C, from chamber C to chamber D, and then out, right? Obviously, like not out because that would be systole, but you kind of get the drift. It's diastole is how we're moving things throughout my heart, right? So if the diastolic pressure is equalized in all 4 chambers, there's no pressure gradient and there's no forward flow, or at least very minimal forward flow. So if the fluid can't move forward, it might move backwards, right? And so obviously if the fluid can't move forward, the cardiac output is going to be very low, right? Heart rate times stroke volume. So that's why this patient has hypotension. If the fluid can't move forward, it's going to move backwards. That's why they have JVD, okay? And then you hear the muffled heart sounds because they've got a big old fluid surrounding their pericardium, surrounding their heart. So it's going to be really hard to hear heart sounds. That fluid surrounding the heart is also the same reason we see low voltage and electrical alternans. Okay. So if you think about it, right, we put our leads on our chest, and the heart is signaling it's doing electrical conduction, and those leads on the chest are picking up that electrical conduction. So if I have some fluid in between, it's going to impede the EKG leads from picking up the electrical conduction, right? So that's why the QRSs come up a little bit small. Now, low QRSs are not specific to a pericardial effusion or tamponade, right? Other things can cause that. Think about if you have a really obese patient that just has a lot of fat in the thorax area, that's going to impede electrical signaling. You guys will learn about COPD next block, where patients have hyperinflated chests that can impede signaling. And then if the heart is pretty weak itself, or you have underlying conduction disorder, that's going to impact signaling as well, and you're going to have low voltage QRS. And now this electrical alternans occurs because when this heart is in this pericardial sac that's got a lot of fluid in it, every time the heart contracts, it kind of swings in this fluid. And so sometimes it'll contract and swing closer to the top of my chest or to anterior chest. So it's closer to my leads. And so the EKG leads can pick up the signal, the ventricular contraction a little bit better. And then on the next beat, it kind of swings back to like more posterior in my chest or posterior within the sac of fluid. And so now it's further away from my EKG leads, and the QRS leads will be back small again, right? So if you look here, right, this one, the heart was probably up tight on the fluid, and now it contracted, and now it's swung back and it's further away. And now it's closer, and now it's further away, right? Same thing like that. And then they kind of put it together. We think about metastatic lung cancer, right? So this patient might have what's called a malignant pericardial effusion. You guys have learned about a lot of different causes of pericarditis. The most common cause is a viral infection, right? And usually it's like we don't even know which kind of virus, right? We can't test for every virus. But you also have bacterial infections, fungal infections, malignancy in this case is a common cause, radiation to the chest, certain endocrine disorders, uremia can cause it, right? Autoimmune disorders, so many causes of pericarditis. But now when I put the picture together, I see Beck's triad. I see a patient with a history of metastatic lung cancer that can easily metastasize to the pericardium. It's right there, and it does it actually decently often. And then I see low voltage QRS plus electrical alternans. In my head, yeah, this is cardiac tamponade until proven otherwise. And then my right answer is going to be B, a decrease in systolic blood pressure by 20 milligrams on inspiration. So in normal physiology, we have what's called interventricular dependence, okay? When I take a big deep breath in, my chest expands, my diaphragm goes down, and my intrathoracic pressure becomes more negative. So let's just say for the sake of like it being easy, right now, while we're just sitting here and you're not taking a big deep breath in, your intrathoracic pressure is like 0, and let's say your venous pressure is like 20, right? Positive 20. So pressure is going to go from high to low, right? So the pressure in my veins is higher than the pressure in my thorax, so it's going to push blood back into the right side of my heart, right? Through the IVC, the SVC, right? And the carotid sinus. When you take a big deep breath in, your chest expands, or your lung expands, your chest expands, your diaphragm goes down, the intrathoracic pressure goes from like 0 to let's say -5. Well, now the difference in between my veins and my thorax went from 20 to now it's 25, right? The difference is even greater. So it's going to bring more blood back to the right side of my heart. It increases venous return, okay? So if that doesn't really make sense yet because you haven't done respiratory, just think about a huge inspiration increases venous return, it increases preload, okay? So in this case, right, we're increasing blood flow back to the right side of my heart. The right ventricle is pretty weak, right? It'll expand, but in order to expand, it kind of kicks the interventricular septum over just a little bit, and that kind of closes off. Like, so my left ventricle is normally this open, but now it's kind of just a little bit more closed because the right ventricle has kind of kicked it over a little bit. So on the next beat, the left ventricle is able to hold just a little bit less blood than it normally could. So your systolic blood pressure on that next contraction will be slightly lower. It'll be lower by less than 10 millimeters of mercury, right? So maybe while you're just sitting here, your systolic is like 120. You take a big deep breath in, your systolic is like 116, right? Totally normal as long as the change isn't more than 10 millimeters per mercury. If you have a patient with cardiac tamponade, right, where diastolic pressures have equalized, flow can't really move forward as well. It's going to move backwards. All that fluid is sitting in the right ventricle because it can't move, right? You have the patient take a big deep breath in. It's still going to bring that blood back to the right side of my heart. That right ventricle is going to really expand. We're going to kick that interventricular septum way over into the left ventricle, and we're almost going to like occlude it, right? So on this next beat, right, the left ventricle can't really accept any blood, right? It'll accept some, but it'll be a very small amount. So now on the next systole, there will be a huge difference in systolic blood pressure. The systolic blood pressure will drop by at least 10 millimeters of mercury, if not more. Okay. So I think about it like a transient hypertrophic obstructive cardiomyopathy, like on steroids, right? Because like in HOCM, the interventricular septum is hypertrophied. It's really kicked over. In this case, like the right ventricle is like pushing the interventricular septum over. And so you can see a drop in systolic blood pressure on inspiration by more than 10 milliliters of mercury. We call that pulsus paradoxus. It's quite specific for cardiac tamponade. Okay. Answer A, a holosystolic murmur at the left lower sternal border that increases with inspiration. That'll be tricuspid regurg. Remember, if we're inspiring, we're bringing more blood back to the right side of the heart, and it's a really flimsy valve. It's incompetent. So if I'm bringing more blood across an incompetent valve, that murmur is going to get louder. Warmer extremities, absolutely not, right? This would be an example of obstructive shock. We're not having forward flow. My extremities are going to be really cold. In unilateral painful and erythematous calf could be a DVT that maybe progressed to PE, but I'm not seeing enough here to kind of key me in on PE. I'd want to see tachypnea, tachycardia, dyspnea, hypoxemia with an underlying risk factor, and I'm not seeing that here. The underlying risk factor could be known cancer, but I'm just not seeing enough. And these low voltage and QRS and electrical alternons is pointing me more towards cardiac tamponade. And then bounding carotid pulses would be seen in a hyperdynamic state like high output heart failure, like wet beriberi, sepsis, anemia, cirrhosis, Paget's disease, carcinoid syndrome, hyperthyroidism, right? Or aortic regurgitation, which we're not dealing with anything here. All right. So there you go. If you want to read my explanation, here you go. You can take a screenshot, and then I'm going to move on. All right. We have a 22-year-old athlete has exertional syncope. Systolic murmur is best heard at the left sternal border. It becomes louder with standing and softer with squatting. What's your diagnosis? So think about A through E, pause it. So your answer is going to be HOCM here, right? So first off, it's a younger athlete, right, who has exertional syncope. That's a red flag, right? You remember, like when you're out playing soccer, do you guys have like exertional syncope? Like syncope is a transient loss of consciousness? No, right? If you're healthy, you shouldn't, right? So this is a big red flag for an underlying cardiac problem. When the key for this question is really just worrying about what happens with standing. So remember back from my cardiac physiology lecture that I gave like 2 weeks ago. For most murmurs, when I stand, my preload goes down, right? When I stand, the blood is pooling more towards my lower extremities for a little bit. And so if I'm decreasing my preload, there's less flow across the regurgitant murmurs and the stenotic, or the regurgitant valves and the stenotic valves. Okay, so the murmurs should become more quiet, right? But in this case, I'm reading it and it says the murmur becomes louder with standing, right? So then I would just remember, okay, the only murmurs that should get louder with a decrease in preload are HOCM and mitral valve prolapse, right? Mitral valve prolapse is not on this list, and mitral valve prolapse also probably shouldn't cause exertional syncope. So when you think about HOCM, it kind of relates to that interventricular dependence we just talked about in the last question. The interventricular septum is quite large. It's pushing over into the left ventricle. So when I decrease preload, that interventricular septum's way over, and any blood that's in the left ventricle is just going to slap across that left ventricle as it kicks out right into the aorta and out into the system. When I increase the preload by doing a couple things, like I could give the patient fluids, I could do a passive leg raise. When I increase the preload, we're shifting that interventricular septum almost back over to its normal spot. So now when the left ventricle contracts, a lot of that fluid can go up without smacking against the interventricular septum, and we decrease the murmur intensity. The other one you should be aware of is the Valsalva maneuver. The Valsalva maneuver is bearing down, it's increasing my intrathoracic pressure, which decreases preload. So it's the exact opposite of what we talked about with inspiration. With inspiration, I'm making my intrathoracic pressure more negative, which drives venous return. With the Valsalva, I'm increasing my intrathoracic pressure. So I'm making the pressure gradient smaller between my veins and my thorax, which reduces venous return. And as I taught you in the last video, right, of that, you're literally like, Adam, what the heck are you talking about? Valsalva decreases preload. Okay, that's all you need to know. And the V in Valsalva, if you look at it, it's an arrow pointing down, so it decreases preload. Most murmurs should decrease intensity with preload, but HOCM and MVP actually increase intensity. Okay, that's what I want you to know there. Let's keep it moving. All right, we have a 72-year-old with bradycardia. The EKG is shown. What's the best diagnosis and management? So pause your screen, consider the underlying rhythm, and then what you want to do for this patient. All right, so this is going to be your Winky Bach here. If you take a look at your rhythm, so there's the answer, and there's your explanation if you want to kind of read it, and I'm just going to go through it. Your Winky Bach here, if I look right, here's my P wave, here's my QRS, there's my T wave, there's my next P wave, and I look, right, this one looks relatively good, right? The P wave should be 3 to 5 small little boxes. This one's getting longer, and then, oops, we dropped it, right? Because I can see the next P wave right here. And then we go back to normal, a little bit longer, oops, we dropped it again. And normal, longer, oops, we dropped it again, right? So longer drop, now you got a Winky Bach, right? Second degree AV block, type 1. Second degree type AV block, type 1, and first degree AV block, where my PR intervals are just longer, we never drop a beat. Those are usually above the level of the AV node, okay? So we're still able to pick up our bundle of His and kind of still continue contractions beyond the block. Those are relatively benign, and we just watch them. If we get blockade below the level of the AV node, so those would be things like second degree type 2 and complete heart block, that's when we want to put a pacemaker in the patient, okay? So it'll be option B, all right? So observe if asymptomatic. Obviously, if for second degree type 1, if they do have symptoms, we could consider a pacemaker for the sake of step 1 and at least step 2. If they give you a patient with Winky Bach, they're probably not going to have symptoms. They wouldn't give you something like that, all right? There's your answer if you want to, again, screenshot or take a look, and we'll move on. All right, another rhythm. So this is a 70-year-old with a prior anterior MI. He's presenting with fatigue and 1 episode of pre-syncope. So syncope, transient loss of consciousness. Pre-syncope would be like all the feelings like you're going to pass out, but you don't, right? So they might say they get really hot, they get flushed, they get sweaty, they feel tunneling of their vision, they feel like they're going to pass out and lightheaded, but they don't, right? Okay, and then pre-syncope would be actually losing consciousness. Here's the EKG. What do you want to do for this patient? So pause your screen and consider. All right, in this case, right, I take a look at my PR intervals, nice and neat. There's my T wave, right, definitely stopping in between halfway. We're good, we're good. Oops, we dropped a beat, and then back to normal, right? So we're normal, we dropped. That would be second degree type 2, like we just discussed. In this patient, we want to put a pacemaker. Atropine is not going to work in these patients. Atropine could be a decent option for a patient in sinus bradycardia as like a transient fix. We got to figure out why they're in sinus bradycardia. But like in conduction block, me giving the patient atropine is going to stimulate the M2 receptors, or it's going to, antagonize the M2 receptors on the heart, which is going to increase the heart rate. But if the patient has a conduction block, it doesn't matter if I'm antagonizing those M2 receptors, because there's a huge block below the level of the bundle of His. We're not going to be able to really get much of a signal out. That atropine's not going to really work for us. We need to put a pacemaker in these patients. All right. Adenosine would be a great option for supraventricular tachycardia. So those would be things like AVNRT and AVRT, where we get some sort of either a re-entry circuit around the AV node or re-entry circuit, like a macro re-entry circuit, such as like the bundle of Kent and Wolff-Parkinson-White. Adenosine could be a good option, a good first pharmacological option, as it stops flow or it stops conduction through the AV node very transiently. For those patients, right, they're going to feel palpitations. Their heart rate's going to be 150, 200 beats per minute. If it's Wolff-Parkinson-White, we'll see the short PR, the slurred delta wave, the wide QRS. We often try vagal maneuvers first, so carotid massage, Valsalva, putting their head in ice water. We try those first. If those don't work, then we can consider adenosine. And so that would be like the carotid massage would be an example of a vagal maneuver we could do for supraventricular tachycardias. All right, there's your answer if you want to kind of screenshot and take a look. And let's keep it moving. All right, we've got a 63-year-old with ischemic cardiomyopathy presenting with palpitations and lightheadedness. His blood pressure is stable. What do you want to do for this patient? All right, this one's a tough one, and I don't really expect you guys to know management for ventricular tachycardia, but I'm teaching it to you in case it does show up. In this case, right, when I'm taking step one or step two, if it's a wide complex tachycardia, it's most likely going to be ventricular tachycardia. Obviously, there's a few other causes. There's something called supraventricular tachycardia with aberrancy, which would be a supraventricular rhythm, right? Like we talked about AVNRT or AVRT, for instance, with a bundle branch block that can then cause my QRS to be wide, right? It's pretty trippy. Don't worry about it as a first or second year medical student. Also, you could have polymorphic ventricular tachycardia, something like torsades, where the R waves go up and down and up and down and up and down. If you take a look at this, right, these are all wide complex QRSs, but all the R waves are pointing downward, right? So it's what we call concordance. There are a few other things in this EKG that point me more towards ventricular tachycardia, but they're far beyond what you need to know as an M1 or an M2 before step one. All I want you to know, if you look in the literature, wide complex tachycardias are like 80% of the time they're ventricular tachycardia, right? So if you just had to guess, ventricular tachycardia. Then as the patient gets older, okay, and if they have underlying structural heart disease, it's almost like 100% that a wide complex tachycardia is ventricular tachycardia, okay? This guy is a little bit older and he has structural heart disease with a wide complex tachycardia. This is ventricular tachycardia until proven otherwise, right? The underlying heart disease, it sets up an ectopic foci. It causes fibrosis and scarring, sets up a place for an abnormal rhythm to begin from somewhere in the ventricles to kick off this ventricular tachycardia. As long as they're hemodynamically stable, amiodarone tends to be the first option, right? Amiodarone is a class 3 antiarrhythmic, but it also has class 1, 2, and 4 properties. Whenever we're starting a patient on amiodarone, we like to check their pulmonary function, which we'll talk about how we do that in respiratory. We check their thyroid function. We'll talk about that in endo. And we check their liver labs and their liver function. We've talked about that already in gastro. So they love to ask you about side effects of amiodarone. So it's pulmonary fibrosis, thyroid disease. It can cause hyper or hypothyroidism, and then liver damage. Okay, so those would be the big ones. PFTs, TFTs, LFTs, move on. All right, next. Here's your answer if you want to just read it and screenshot, and then we'll move on. All right, 58-year-old with N-STEMI is started on heparin. Which lab is most appropriate to monitor unfractioned heparin therapy? So A through E, pause your screen and consider. All right, so it'd be PTT, right? This is bringing you back to heme a little bit, but it's an important concept because you're going to be putting a lot of patients on heparin and potentially even warfarin, right? When I think about my clotting cascade, we've got two major pathways. We've got our extrinsic pathway, or the tissue factor pathway, as sometimes it's called, where it's factor 3 and then 7 and then 10-5-2-1, 10-5-2-1 being my common pathway. And then we have my intrinsic pathway, or the contact pathway, that goes 12, 11, 9 plus 8, 10-5-2-1. So warfarin is really important because it blocks vitamin K epoxide reductase, which is used to reduce vitamin K, or take vitamin K and reduce it. And reduced vitamin K is used for gamma carboxylation of factors 2, 7, 9, 10, protein C, and protein S. So of those clotting factors, not of the anti-clotting factors like CNS, of the clotting factors, factor 7 has the shortest half-life. So warfarin is going to pretty quickly alter your PT or your INR. So that's why we use the PT to track your warfarin levels, right? For heparin, right? Heparin blocks factor 2, right? So it modulates antithrombin 3, and we electrostatically block or bind to factor 2, which is thrombin. And then we also block factor 10. And so that's going to have more of an impact on your intrinsic pathway, and which is measured by your PTT, because in this case, we're still making vitamin K. We're still able to make and produce factor 7, right? So the PT tends to stay normal unless you have a patient on a really high dose of heparin for a really long time. So that's what I wanted to remind you of that. Go back to my heme lecture. We also talked about heparin-induced thrombocytopenia, which is a very classically asked question. I have already treated at least 4 patients with it, just off the top of my head. Very common in the hospital. Be aware of it. All right. We have a 60-year-old who's discharged after STEMI, treated with a percutaneous coronary intervention. There are no contraindications. Which combo provides the clearest mortality benefit long term? So A through E, pause your screen and think about it. All right, so this one's B. Not always the case, but whenever you're doing a standardized exam, I like to think the longer the answer option, it's almost always the right answer. It's not always right. So do your due diligence, read all the answer options, and then really scrutinize the longest answer, right? Because the longer the answer, the more room there is for them to kind of sneak something in. So like in this case, if I gave you like a drug that wasn't indicated, right? That would eliminate the whole answer option. So really do your due diligence. But after a myocardial infarction, some of the drugs I want to keep the patient on are aspirin and a P2Y12 inhibitor. Okay, so that would be things like clopidogrel, prasugrel, ticagrelor. If you look at the literature, prasugrel and ticagrelor tend to be used more, or they tend to be favored more than clopidogrel. That's kind of a story for another day, more than you would need to know for step one. We also can't use prasugrel if the patient has a history of stroke or TIA. That's just more for your knowledge. But we do antiplatelet therapy, right? Because the patient's in a hypercoagulable state, and we just put a foreign body into their coronary vessels. Statin, obviously, to protect, lower their LDL, protect against oxidative damage, right? Cause plaque stabilization. Beta blocker to reduce myocardial oxygen demand, and then an ACE inhibitor, right, to reduce their blood pressure and hopefully prevent some of that cardiac remodeling. Nitrates and renalazine would be decent options if the patient had angina. Remember, your beta blockers and your calcium channel blockers tend to be first line there. Digoxin and loop diuretics are great for heart failure. They're good for symptomatic treatment. They do not have any mortality benefit. Verapamil is a non-dihydropyridine calcium channel blocker, right, to lower chronotropy and inotropy. Again, can be used in a number of arrhythmias and for angina. And then furosemide, we talked about hydralazine, tends not to be used as much. It has been proven effective to reduce mortality in certain instances of heart failure in certain individuals. It's been well studied in African American individuals, and it does slightly lower mortality. It's not really used as much. Okay, probably never the right answer on a board exam unless you're dealing with a pregnant woman with hypertension, which we'll talk about in repro. All right, almost done here. 65-year-old male presents with crushing chest pain that radiates to his right arm. He has tried antacids and lying down, but has not found relief of his pain. He tells you he has a history of coronary artery disease and type 2 diabetes, both semi-controlled on drugs. The EKG is shown. His high sensitivity troponin is significantly elevated on arrival. Vitals are currently stable. I want you to think about what would you do for this patient. All right. So his vitals are stable. His troponins are elevated. Take a look at the EKG. I'm sorry, it came out a little blurry. And think about what you want to do for this patient, right? So pause your screen, come up with your plan, and then we'll discuss. All right, so this patient definitely has a STEMI, right, in 2, 3, and AVF. So if you go back, right, you can see in 2, the J point's elevated, and 3, the J point's elevated, and AVF, the J point is elevated. And then if we look on the anterior portion of my heart, 1, 2, 3, and that's usually about that. That's about it. They have ST depressions, which would be my reciprocal change, right? So if the inferior portion of my heart is completely occluded as a myocardial infarction, as STEMI, we have a reciprocal change where the anterior portion of my heart tends to show ST depression, right? So in this case, right, we have enough. Here's your definition of STEMI, right? I've taught you guys this before. Usually we want to see a 1 millimeter change in all the leads. V2, V3 are kind of the weird ones where you like to see a higher change. But for the sake of an M1 or a patient or someone who's about to take step 1, just think about an increase in the J point in contiguous leads. So by contiguous leads, that would be 2, 3 AVF, which impact or tell me about the inferior wall. It would be 1 AVL, V5, V6, which tell me about the lateral wall. And then it would be V1 through V6, essentially, which is like my anterior septal wall. Those are contiguous leads. So management for STEMI, we try as long, we hope to God that we have a hospital that is a PCI capable hospital, right? But sometimes in like rural areas, they don't have access, right? We try to do door to balloon time meaning when we insert the balloon into the coronary artery to expand it, which is a PCI, right? We try to do that within 90 minutes. We can extend it up to 120 minutes if we have to transfer the patient to another facility. If we don't think we're going to be able to do it in 120 minutes, if we can't transfer them, we'll usually start TPA and then still try to transfer them. Again, kind of more advanced concepts, but I want you guys to get into the framework. And then I taught some of you guys this concept of Mona Bash. So the Mona, like Mona Lisa, and then Bash, right? BASH. So the M stands for morphine. The O is for oxygen, which we could give when it's less than 90%. The N are nitrates. The A is aspirin. The B is beta blockers. The next A is ACE inhibitor. The S is statin, and then the H is unfractionated heparin. We also sometimes give a P2Y12 inhibitor before or directly after PCI, right? That we kind of leave that to cardiology, how they like to do it. Morphine tends to not be used as much anymore because it decreases your gastric absorption of P2Y12 inhibitors. But if the patient's in a lot of pain, we might use it. And then I taught a lot of you guys, if the patient is unstable, hemodynamically unstable, we want to avoid nitrates or beta blockers, okay? This most commonly happens with posterior and inferior MIs. So just like using an inferior MI as an example, the inferior wall of my heart is primarily my right ventricle, okay? And the right ventricle is primarily supplied by the right coronary artery in about 85% of my patients. The other 15% tends to be the left circumflex. That right coronary artery also supplies the SA node in 60% of patients and the AV node in about 90% of the patients. So if I have an inferior STEMI, there is a chance that the right coronary artery is significantly occluded and we have cut off blood supply to a lot of the right ventricle. Now the right ventricle can't push blood into the left ventricle. Okay, the left ventricle's preload is way down, cardiac output is in the dirt, right? So they're going to be blood pressure 80/40, right? And now if the right coronary artery is impacted and it's causing ischemia to the SA node or the AV node, their blood or their heart rate might be like 50 beats per minute or 40 beats per minute. You guys have learned about the baroreceptor reflex. If your blood pressure is low, your heart rate should compensate accordingly, right? So if their blood pressure is 80/40 and their heart rate's 50, that's abnormal, right? That's not correct. So we'd want to avoid a nitrate because that reduces myocardial oxygen demand, causes vasodilation, reduces preload, which is going to make their blood pressure worse. And we want to avoid beta blockers because it'll also do the same thing and it'll decrease contraction of the heart and their heart rate will now be 0, right? And you just killed your patient. So doing this Mona Bash is not always the correct answer. You really have to look at who your patient is. And then just for your sake, if it's an NSTEMI or UA, depending on the severity, we can actually hold off on doing a PCI for a couple days, even if it's not as severe, but same medical management. All right. Here is just it's from one of the textbooks I read. I'll just let you pause your screen and take a screenshot. It's literally everything we just discussed. But if you like seeing it more in algorithmic style, there you go. All right. Just a couple. All right, this is the last one. Septic patient is hypotensive, warm extremities, bounding pulses early in the course. What do you expect their hemodynamic profile to be? We're thinking about systemic vascular resistance, cardiac output, and post-capillary wedge pressure. Think about A through E, pause your screen, and then we'll go over it. All right, and this one is going to be B. So really when I think about shock, I'm actually going to jump to this slide first. There's 4 different big categories. There's I think about it as my pump, my pipes, and my tank, okay? My pump would be cardiogenic and obstructive shock, right? In cardiogenic shock, the most common cause leading to cardiogenic shock is an acute myocardial infarction. Your heart is just puttered out, right? We can't pump blood forward, okay? In obstructive shock, things like cardiac tamponade, tension pneumothorax, a massive PE, constrictive pericarditis, those constrict or obstruct forward flow from the heart, right? So both decreasing forward flow. The next kind of cause of shock, so that was the pump. The pipes would be something like my distributive shock, right? In this case, there's multiple types of distributive shock. The most common cause is sepsis or septic shock, but other causes you want to consider are anaphylactic shock, adrenal insufficiency, which we'll talk about in endocrine, and neurogenic shock are just some of the big ones just off the cuff. In this case, the systemic vascular resistance is really low. They all stem from an over vasoplegic state of these vessels, right? The vessels get really leaky for whatever reason, right? In sepsis, it's in a huge inflammatory response. These cytokines make everything super leaky. So the key pathophysiology there is low systemic vascular resistance, okay? And then you think about your tank, which would be things like hypovolemic or hemorrhagic shock, where the patient just got in a huge car accident and they're bleeding out. They've just got less blood to give out, okay? And so shock in general, at its core concept, is a mismatch between oxygen delivery and oxygen extraction that has now caused end organ dysfunction, right? At the level of the mitochondria, we can no longer make ATP, we lead to end organ dysfunction. So in septic shock, right, septic shock or distributive shock, right, is kind of a weird one because again, the core pathophys is a systemic vascular resistance is low, okay? Heart rate or cardiac output is my heart rate times stroke volume. And so because the systemic vascular resistance is low, the heart's like got like a free pass. Like it doesn't have to pump against much afterload. And so the heart is going to try to overcompensate and we're going to try to increase the cardiac output. So oftentimes sepsis is what we call a hyperdynamic state where the cardiac output can really pump up because our body is sensing that there's less oxygen extraction, right? Because in septic shock, it's a cytopathic hypoxia. The mitochondria itself in the cells are dysfunctional because of all this inflammation. And so your body is sensing, hey, we're not getting the oxygen at the level of cells we need. Heart, you got to pump faster, right? So the cardiac output increases. And then we can also see the postcapillary wedge pressure can be like relatively normal or potentially slightly low due to all this like venodilation from like this vasoplegic state, okay? PCWP isn't one that's like often tested in like septic shock, but oftentimes because it's such a venodilated state, there's less buildup of pressure in the left atrium because that's what my postcapillary wedge pressure tells me is it's the pressure in my left atrium. Okay, so when I think about it, right, this one is low, and then this one is elevated, the cardiac output. So that's the only one that's a reasonable option. So even if you didn't know, you were like, I'm not sure on the PCWP, the systemic vascular resistance and cardiac output, you should be able to kind of reason through, and you could answer this right. If we have cardiogenic shock or obstructive shock, the cardiac output is low, right? In cardiogenic shock, the heart can't pump. In obstructive shock, we just can't get any fluid out because there's a massive obstruction. In cardiogenic and potentially obstructive shock, depending on where the obstruction is, we can get a massively elevated postcapillary wedge pressure, right? Left atrial pressure. Obviously, if it's like a massive PE, the PCWP, it might be low or it might be normal because there's less fluid actually going to the left heart. And then in hypovolemic shock or hemorrhagic shock, the systemic vascular resistance should be high, as it would be in cardiogenic and obstructive shock, because in that case, there's less forward flow to the JG cells. Okay, renin-angiotensin system goes sky high. We clamp down on all my vessels. We try to increase the systemic vascular resistance to maintain some sort of pressure out in the periphery. And then in that case, right, depending on the fluid in the system, the cardiac output is usually pretty low if they're losing out all their blood, right? Because your heart rate can compensate for a while, but your stroke volume is going to be in the dirt if we're losing all of our blood. So eventually the heart rate just can't stay up that long, right? And the cardiac output ends up dipping down. So that's kind of like a really brief framework for shock. You will see shock over and over again. Do a rotation in the ICU. Your fourth year at MCW or whatever medical school you go to, and you'll come to appreciate shock. Very complex topic. You as an M1 are only supposed to know the bare minimums. Okay, so that was everything in 45 minutes. Hopefully that helped kick some butt on your exams if you're taking them at MCW or if you're just watching this video. Good luck on whatever exam you're taking. Reach out if you got any questions.